Thank you, Craig. As most of you know, Craig and I had almost parallel careers, and we started in Bermuda in 1981, 82, I guess, and has been a long-term friendship. I think we are all, and this goes to all of you, a very privileged group of people. I have been saying this from the time I finished medical school. I'll do what I do for free, anytime. And they pay me to do what I love to do. I mean, that's how many people in society can say, I get up in the morning at 6, I work until 9 o'clock at night, and I'm the happiest person on earth, and with the money in the pocket. I mean, not much money in Canada, but money enough to live well. Again, what I'm going to tell you is largely personal experience rather than data. I never liked the aorta beyond the subclavian. And again, it goes, to be quite honest, it goes back to the goddamn paraplegia. It destroyed me. And if you replace a aortic abdominal aorta, and go make rounds next morning, and the guy is incontinent, cannot control his bladder, doesn't pee well anymore, and worst of all, in a wheelchair. That stuff destroyed me, partly because of my Latin personality, or who said yesterday, Dave Adams said in his presidential address, well, he cares, and I do care, and I feel guilty. A patient come to my office, very strange to me. Why do you spend your 247 mental education to take care of the patient? Because of me, not because of the patient. That's my work ethics. Anything beyond the subclavian is bad. There used to be a vascular surgeon, by the way, but I like it below the diaphragm as well. I didn't like anything between the subclavian and diaphragm. But then, of course, Maral came along, and I put in a silver platter, I can take them all. I don't want to see these patients anymore. And my focus has been largely in the proximal part of the aorta, and to be quite honest, mostly in the aortic root. I mentioned yesterday the form follows function. It's very applicable to the mitral valve, even more applicable to the aortic valve. Unless you know anatomy in detail, and I have had a few problems with my hand, I broke some bones, and my musculoskeletal system is another one where form follows function. I mean, if you lose a leg, you lose a knee, you realize how important the function that anatomy is. To repair, to reconstruct, to operate in the aortic valve, you have to know as much anatomy as for the mitral valve. Well, Dr. Shumway had this idea of transferring the pulmonary of dogs into the aortic valve. Donald Ross took the idea and put it into humans in 1969. It became known as the Ross procedure. And that's a spectacular operation. Spectacular operation because the last 6 months that we lived inside of our mothers, our pulmonary valve and aortic were identical. No difference at all. The pulmonary valve, the moment you took first breath, began to change because the pressure dropped. But then, God forbid, when you're 10 or 12-year-old, you develop primary pulmonary hypertension. The pulmonary valve changed again, the same way it was inside of our moms, inside the uterus. Become thicker, adapt. How many of you have seen a patient with primary pulmonary hypertension and an aneurysm of the pulmonary valve? I have seen some, but they have Marfan syndrome, they have Low-Digit syndrome, which is the same connective tissue disorder that affects the aorta. So you have to understand that when you change the pulmonary from the pulmonary position put in the aorta, it's going to work okay. Very likely it's going to adapt to the aortic position. But you cannot alter the anatomy. If the pulmonary valve is going to be transferred to the aortic valve, you better know the anatomy of the pulmonary valve and make the pulmonary valve anatomically perfect, like was in the right side of the heart. And then there's a reasonable chance that this operation works well. I started doing Ross about the same time as I was learning about valve sparing and valve repair. So I had the advantage of knowing anatomy. And our results have been outstanding. We're not going to print this yet because there are 17 patients in this group who have not had echo yet to publish 30 and 35 years. Survival, of course, is excellent, but my patients are very young. They're 34-year-old. But very, very few failure rate. And if I read back my honest operative report, I have 2 operative notes for every patient. One for the records, for the medical records, one for my records. My records is raw. You tell all the boo-boos I made in the operating room. And we make mistakes, you are humans. But in case I made no mistake, the valve is perfect. So I do believe in this operation, and I'll hope to publish this year once I get 17 more echoes in. They're all international patients. To chase them is very, very difficult. You can find if they're alive or dead through all these popular medias we have there. And that's what my research nurse is doing now. She putting in Facebook, in Instagram, and they reply. If it's important for the Ross, it's even more important when you do valve sparing. And there is a pretty high proportion of humans, and some of you here may have, dilatation of the aortic root, which is the most common cause of the aortic valve dysfunction in the Western world, like in every part of the world, but they don't diagnose. If the cusps are normal, I think it's tragic to do a bento. I introduced bento to Canada, by the way, when I started practicing. I think it's a wonderful operation. But it bothered me in 1980 until 1985, 86, that I was doing bentos in people with normal aortic valve. So it made no sense to me. Why am I doing a bento? I'm chopping this valve. Look at these cusps. I hope my cusps are good at those 3 cusps in this patient. And this patient is pretty old. What I have learned, there are 2 types of patients who develop aortic insufficiency or dilatation of the aortic root. One patient is like who I am. You're old, you're 60, 70, 80-year-old. You do an echo and the aorta is dilated, you might have severe AI, but the aortic annulus, the aortoventricular junction, doesn't change. I don't know if you echo, all of you here, the average size of the aortic annulus. It's very small. Scary small. I can tell you, all of you here who don't have aortic valve disease or bicuspid aortic valve, or ends between 17 for the women, 18, up to 22, 23 for guys like myself, Craig, Joe Coselli, who are a bit taller, and it's very small. If the annulus is small, the disease likely are purely arterial. It doesn't affect the fibroskeleton on the heart. So why to replace the fibroskeleton when you do an operation? We measure all of this before, and if the annulus in a 60, 70-year-old is normal, the operation that should be done is what we coined the term remodeling. And there are various types of remodeling. Remodeling was first published in 1995, because the editor of the journal said, you have to classify of this. First, we introduced valve sparing operation to differentiate from valve repair. Then in 95 or so, the editor said, it's confusing, valve sparing, valve repair, and there is various type of valve sparing. So we divide in remodeling or reimplantation. And was the best term for a non-English-speaking person could describe this. Simple adjustment of the sinus-to-blood junction in the elderly patient, when I say elderly, anybody over 50 or 60, cures the aortic insufficiency. You might have to repair the cusp as well if it's overstretched. Sometimes only the non-coronary sinus dilated, very high proportion. Sometimes two sinuses are affected, right and none. The left is the least one involved. And it's a simple operation for all three. And likely, functionally, a better operation. Better form follows function. This patient has only moderate aortic insufficiency, aorta of 58, 59 millimeter. The patient is 69-year-old. Why in the hell are we going to replace this aortic valve? No, we don't replace. We make every effort to save this aortic valve. Put the patient on bypass, transect the aorta. I think I told you about, we cannulate the coronary arteries and let the perfusionists keep the heart alive. Just they keep the whole body alive by pumping blood for the whole body. Tell the perfusionists, 500 cc's every 20 minutes, every 30 minutes. And you don't worry about this anymore. And then you can do an operation. Transect the aorta just above the sinotubular junction. And now, with a sizer, try to find the way. Look at the right cusp and non-coronary cusp. Both are prolapsing a bit. Determine the ideal size for the sinotubular junction. Well, I don't know if it's 24 or 26. What do I do now? How is the bigger? Because you put a 26, and there's some AI you can placate to make 24. Divide in 3/3, not equal thirds, but according to the intercommissural distance of the given cusp. Try to reproduce how nature is done. And then recreate a sinotubular junction by putting the graft into the sinotubular junction. In other words, just above the commissural level. So now you are recreating a new sinotubular junction, which is the normal one. Instead of the 45 millimeter, the size of this graft, which I don't remember what it is, usually 24, 26, 28 for human beings. You don't need larger than 28 sinotubular junction, even a large patient or patient with a large cusp. And then, of course, once you recreate it, now you have to explore the cusp, make sure they're all praying to God to work well, otherwise you're going to have a bad reputation. The cusp is going to be like up in the air, up inside the aortic root. And we can do that very simply by taking a 5 or 6 proline and plicating the central portion along with the nodules of Arantius, which is the thickest portion of the cusp. You have to obliterate that cusp. If you have a good sonographer, you can clamp the aorta, give cardioplegia, and they can see, even if the heart doesn't beat, if that continuous flow or not. I can tell you from experience, if the heart doesn't distend, there's no AI. Because mild AI, in the first minute of cardioplegia, the heart blows up. Those are distal anastomosis, and the operation is done. That's the simplest aortic valve sparing you do, and it's a fairly common in older patients. You don't have to replace the sinuses. You don't have to replace the annulus. Of course, sometimes, this is another very older woman, huge aortic arch, huge descending aorta, in heart failure. But look at the aortic root in the second central slide, where the right coronary artery is, where the left coronary artery is. There's a beautiful ridge, the sinotubular junction. But she lost the non-coronary sinus, sinotubular junction, and the sinus. So calculate, take a graph that reestablishes the distance to allow the cusps to touch each other, and create a tongue of tissue. Make the tissue as tall as the diameter, so it bulges a bit, like a normal sinus. And then, of course, the same thing. And the same for if all 3 sinus are needed. Older patient, and was a 23 millimeter, why to do a reimplantation? Reimplantation is a very stressful operation for both patient and surgeon. This is by far simpler. I saw this woman last Tuesday in my clinic because she had atrial fibrillation 31 years after this operation. And so I dig up her video to show to you. This is her in the operating room. She had an operation in 1994, 31 years ago. She's on cardiopulmonary bypass. Look at the videos. It used to be the VCR recording. Maral we have a library of hundreds of videos. She converts all the videos into, which is not the greatest color, but, and the usual. She's on cardiopulmonary bypass, we explore. There's some fenestration, which in those days I didn't care, because I didn't know enough. But, and then, pretty good cusp. Create 3 neo-aortic sign of Valsalva, and then suspend the commissures in the upper part of this tongue of neo-aortic sinuses, and he starts suturing. Just like yesterday when I mentioned reimplantation, you don't suture random. If you suture in the sign of Valsalva, the patient is going to come back to haunt you. It slides over the years. 15, 20 years later, they have another aneurysm, the aortic root. It's almost like a curse. Sign of Valsalva wasn't supposed to tolerate sutures, particularly in a stressful area, keep expanding the aortic root. So one bite goes right into the annulus. The other one comes up to sign of Valsalva for hemostatic purpose only. In the operating room looks perfect, but the small annulus, 20-some millimeter annulus. And when she came to see me, look at that. She came in on Tuesday with this. She had a transesophageal echo because she's fibrillating, and she had to be cardioverted to make sure there's no clot in the left atrium. Just trace AI, 31 years later. So although I don't like remodeling, when correctly applied, is an operation for life. Well, in March this year, I operated on this patient as well. Back in 1990s, I didn't know the difference between remodeling and reimplantation. I did the same operation that the previous patient had, identical operation. The annulus was small, a bit larger than usual, so put a band to reduce the size of the annulus, and look at the size of the signs of Valsalva now. Severe aortic insufficiency. It looks like I never operate on her. When I reoperate on her, the suture line is gently detached from the annulus and form an aneurysm. I told it to other, Gebring has seen the same thing. Was the wrong operation. If someone has a genetic syndrome, this is the wrong operation. Remodeling is a wonderful operation for the older patient. The patient has a normal aortic annulus. Why some people delay the aortic annulus, others do not, I don't know. But if you do have a genetic syndrome, you're going to dilate your aortic annulus, a matter of time. Not a year or two of follow-up, 20 or 30 years of follow-up. I think we should now do reimplantation of the aortic valve in anyone who's under 50 or any age if the N is more than 22, 23 millimeter. And do remodeling of sinus Valsalva, sinus plus 1, 2, 3 on. Jennifer will be talking about reimplantation. And I sound like, again, obsessed, but I am obsessed. I'm obsessed because I'm always looking what's right. Robichek came to me in 1992 and said, David, he never called me Tirone, David, I have a better graft for you. I took the diachron graft, rotates 90 degrees, so it expands now. Said, Professor Robichek, with all respect, I was a 32, 33-year-old, all respect your knowledge and skill, which Tubricar was the genius behind this level, Manu Tubricar. The aortic sinuses are not spherical. There is no sphere in the aortic root. Aortic root, Emmanuel Tubricar is the first one to support me, said, Dr. Davis is right. If you look at anatomy, the aortic root is a cylinder. When I say aortic root, aortic valve function and is structured within a cylinder. To put this cylinder inside of a sphere, that's a major technical error. You're not following nature. You're not form follows function. The only way you can reimplant this valve is in a cylinder. Yeah, but you abolish the sinuses. Well, then, if if you believe in that, create sinuses. We do the way Craig and Miller described. We transect the aorta few millimeters above the sinotubular junction, placate the intercommissural distance, and put a graft 1 or 2 sizes smaller. Oh, no, I like Valsalva. Well, then do what Gebrin does. You love Valsalva, use Valsalva, but then placate the outside of Valsalva to make a straight portion. If you have a cylinder and you placate the curvilinear area, becomes straight. 2 or 3 stitches there, fix Valsalva. So it's not Valsalva that I'm against. It's a misconception that I'm against. Oh, do you do valve sparing in everybody? Of course not. This patient just happened a few weeks ago. And the poor patient is relatively young, no syndromic. But look at the aortic valve. Practically doesn't exist anymore. However, this girl was 16-year-old. The parents said no mechanical valve. So I had a homograft for her. But when I opened being 16-year-old, I said, should I put a homograft or should I try to repair this? It looks pretty miserable too. She had Louis-Gitt syndrome, which we thought was my friend back then. Now with Maral doing genetic studying all these patients, and she had genetic studies 20, 30 years later was Louis-Gitt's, a more benign form. We introduced Gore-Tex in 1994 to save the cusps of some young patients. And we have now 22 years experience with Gore-Tex along the free margin. We, as you can see, we switch the Gore-Tex in and out the free margin, but it becomes part of the cusp. And the few patients we have reoperate on, you don't see Gore-Tex anymore. You see a fibrous band along the free margin. That's a wonderful technique to expand the indication of aortic valve sparing to younger patients in whom you believe that this is likely better than a homograft. This girl, by the way, she was operated in 1998. She's now 41-year-old, and her valve still has only mild AI. So it works. Thank you. Maral is like a sergeant. I kept looking at my watch because I'm 4 minutes over, and she kept with the whip saying, out, and anyhow, next guy here. Oh, any question, by the way? She's giving a few more minutes for you guys to probe my brain a bit more. No question.
Tirone, can I ask a question? I was just talking to Perot about this, how I've struggled to do that 6-0 Gore-Tex along the free edge, because when you tie it, it right away shortens up the whole cusp. So how do you prevent
need a Joanne boss to push the cusp with a suction without like the whole, keep under tension, like a mitral valve, and then tie. And in doubt, always make a bit longer than you need. Every time when you tie, you're going to end up shorting the free margin. I don't think the Gore-Tex is good to fix, to repair prolapse. If there is prolapse, I should placate the nodule frontis and then add the Gore-Tex to reinforce the free margin.
And can I just ask you, because it's been many years since I've watched you do this operation, but are you still doing 9 sutures around the bottom on the proximal suture line for the
9 to 12.
9 to 12 even?
Yeah.
Because as you know, some people do 3, right?
No, well, I try a few, and guess what? They came back with the anodilatation. The graft slides upwards, and too bad it's not here. Duke Cameron has now 6 Louis-Gitt syndrome with false aneurysm subannular by using 3 sutures only. I think if you have a genetic syndrome, you better fix that outflow tract with multiple sutures.
Last question, are you still free tying those sutures? Because I've switched to a Hagar dilator, a small one, like you said. The annulus is small, like a 21 or 22, in order to make sure that I'm tying symmetrically. Or are you still free tying those sutures?
Well, yeah, I do.
Well, you're an artist. You're an artist.
But Mike, we do this operation a lot. Yeah. So it's like anything else, if you do every day, my God, it's
hats off to you, Tirone. Thanks a lot.
Thank you. some of you don't know, but I was breeding Michael Borger to replace me. Then he left me. He found a German woman more beautiful than I am. So I'll take it with the girl instead.